So we're going to speak about definitions first, then we're going to focus on which is we thought that is advantages and disadvantages of this combining technique. Then we go through the more details about the technique of how to do it, and which tips is useful if you want to take over these cases. Then we're going to shift to literature review, because this is a topic is very frequently now published in the last few years, and also there's a lot of you will see that in the papers. There's a lot of controversy about it can be done safely or not. Finally, we're going to speak about our results. So we're going to speak about also how we make it and which results we get it also. And finally, we're going to speak about the summary about that. So first, we start the journey. Why is so different the cultures between Europe and USA? So it depends on how to manage the patients. Usually, American surgeons, they don't do catheter surgery for these patients. They rather prefer, if the patient surgery can be delayed, like a peritoneal membrane, they rather prefer to send the patient to anterior segment surgeon, do the catheter, and then get the patient back to do the vitrectomy to improve the patient. If the surgery cannot be delayed, for this case of macular retinal detachment, then you have to take over the whole procedure here. So probably the patient will, the doctor will take to do the lancectomy here, lay the patient on phakic, solve the retinal detachment, and after that, send to anterior segment to do a secondary implant on these cases. Because the way we are raised in different areas of the world, so Europeans, probably I was one coming from a generation that most of my cases were phaco. So I was trained to do phaco as the regular surgery for catheter surgery. So being doing vitreoretinal surgery, I can be able to manage to do phaco at the same time. That's why in Europe, there's much more will to do these surgeries together than rather than separated the procedures. So let's start with definitions. What we call a combining surgery, it means we do the phaco, we implant the lens, and do the phacovitrectomy at the same act. It's the surgeries all together. Okay. When we speak about sequential surgery, it means we're going to do the catheter first, then they do the retinal surgery in another act, or the opposite way. We can maybe to do the retinal surgery first, then do the cataract later on by another doctor. Okay, so it means two different surgical acts. Okay, so what is that? The indications for phacovitrectomy. There's one clear indication: the patient that they have vitreoretinal pathology that need to be managed, and also they have a visual significant cataract. This is the patient that will be chosen to do phacovitrectomy. Could be a delayed retinal surgery, like there's a peritoneal membrane. We can delay the surgery. The prognosis is not going to change. Or maybe because an emergency treatment that you need to be managed first. So in these cases, we need to manage the retinal surgery and the catheter surgery all together. But we can move a little bit more, because we know that all patients will go to suffer phacovitrectomy. They will have a cataract in the future, in the near future. Almost 100% of the patients, they will have a visual significant cataract in 1-2 years. So if we think about which patients they can be presbyopic, and like a patient like 50 years old, okay? So maybe it would be good if we can be able to remove the cataract, and at the same time we do the phacovitrectomy in these phakic patients. We will be focusing in four group of diseases. First of all, macular diseases. It means peritoneal membranes, macular holes, etc. There's another group of these. We are going to go exactly in these groups when we discuss about literature review. Okay. There's another group of patients that have premature retinal detachment that becomes phakic. We know that if we operate these patients, the patients will have a cataract in the future. So this thing we can be able to manage all together. Also, there's another group of patients, unfortunately very common here in the kingdom. It's a patient with diabetic complications, like vitreous hemorrhage or caso retinal detachments. And there's the last group of patients. We are like a miscellaneous of patients. So we do like silicone removals, foreign bodies, etc. So this not in these three group of pathology. Okay, understood? So, which is the advantages of phacovitrectomy for the patient? So you want to offer the study for the patient, which is the real advantage. The real advantage is we do only one surgery. It's only one surgery act. So for the patient, it means less appointments, and if you pay for the surgery, less cost of the surgery. Why? Because you are going to open operating theater 2 times. Also, if we can be able to do the cataract the same to do the retinal surgery, the visual rehabilitation for this patient is going to be faster. More into that also, if the visual is going to recover faster too for the patient. Also, if we are only going to do one surgery, so the risk of postoperative complications and anesthetic complications is going to be lower. Why? Because we only do one act, not 2 surgeries. These are the advantages for the patient. But what is the advantage for us, for the surgeons? So for us, as a vitreoretinal surgeons, one of the things is very important in several pathologies is to have a good access for the anterior vitreous. So in these patients, we have we make it so the fatigue at the surgery, at the time of the surgery here, we can be able to access better the anterior vitreous. Also, the chance to have a less touch during the surgery is not going to happen because we'll remove the lens on the first moment here. Because we can be able to examine the peripheral vitreous better, we can also to assess better the peripheral vitreous, and we do a better shading of the vitreous and better basal vitreous examination. That will count for to be successful in some procedures. Also, we know that the best moment to remove a cataract is when you start your vitrectomy. So, if you remove the cataract after the vitrectomy, the lens is going to be harder, the thorn is going to be weaker, and you have deeper procedure of the instrument. So, to do a cataract vitrectomized eye is a risk surgery, especially the anterior segment surgery. So, it is better you can remove the cataract at the first time. Also, if the complication arises, it means you have a PCR, you can manage the same procedure, and you can fix everything in the same procedure. You don't have to reoperate the patient again. Also, because we are going to clear the visual access for this patient, we'll be following this patient better, because we can do very early in the post-op assessment here OCTs, instead of using use scan, because you cannot see the fundus because you have a cataract on the patient here. So the follow-up of the patient is also better because you can see clearly what's happened to the eye during after the procedure. But everything in life has advantages and disadvantages. What are the disadvantages of this technique? Because if not, everybody will do it the same thing. Okay, it's longer procedure. So we're going to do 2 surgeries in 1 act. So surgery is going to be longer. Also, if we are not careful during our phaco, okay, we're going to create an edema in the cornea. And this edema in the cornea can preclude the vitreoretinal part of the procedure. So we have to be careful, don't do too much ultrasound to the cornea, because we cannot be able to continue the procedure. Also, usually here, there's a different cultures. Whereas I was trained in Barcelona, we used the same machine to do phaco and vitrectomy. Here, we are very lucky to have an excellent machine, a peristatic pump to do the phaco, and we have a Venturi machine to do the vitrectomy at the same time. But most of the vitrectomy machines we have right now here, like the Constellation and the Stellaris, they are excellent phaco machines. This is something to be clear. So, if we can be able to manage this with these pumps, it's better for the surgeon. But it's a real disadvantage you're not using to work only with a peristatic pump. For some people, there could be a disadvantage. Also, and it's clear, there is more inflammatory response after these combined procedures. Also, it has to be noticed that if the vitreoretinal surgeon is going to do the phaco procedure, it has to be used to work with very advanced anterior segment techniques. So they need to know iris hooks, they need to do CTR, they need to know how to deal with cataracts without red reflex here. Also, we have to deal with capsular opacities, and he has to be very skillful with chopping techniques. Why? Because one of the most important things is try to reduce as much as possible ultrasound for the patient. So if we do chopping, we do less ultrasound for the patient. One thing we're going to view also later on, when we speak about review of the literature here, is we know that if we do phacovitrectomy, the position of the IOL is going to be the same that we do cataract surgery only. And they will can cause problems and the refraction, post-op refraction of the patient. We elaborate more into that. And also, something that people really forget about that is the fellwide management. So let's say I have a high myopia patient, has a retinal detachment, macula on, and they have a cataract. So I remove the cataract, I put intraocular lens, and the patient emmetropic. What I have to do with the other eye, which is myopic 10 diopters? There's something you have to discuss before the patient, because then you have to ask, for instance, the patient, he can't tolerate a contact lens, because they cannot wear glasses anymore. So these things you have to think before going for the procedure, okay? So I'm going to describe very easily the technique. I will show you a video about that. So for me, usually it's a superior approach. My colleagues in anterior they prefer to do it temporal. I say superior, because for me it's easy. I don't want to change most of the times my position in the microscope here. And also, I need the temporal cornea free to put my trocars and everything. So I rather to sit always superior. I put first one trocar at 3.5 millimeters. I will show you exactly when I have the video why. Also, try to be careful. Don't make these corneal incisions in the same meridians that you are planning to put the trocars here. So you have to get one side of the corneas in different meridians that you're going to put your corneal incisions. The capsulorhexis has to be small that you use it for. Why? Because if you do small capsulorhexis, then it's going to be in the back. So when we do fluid exchange, the lens is going to come to anterior chamber, you will have less problems about that. Also, you have to be careful with ultrasound. So you use chopping techniques, you use ultrasound, the cornea is going to do better. When you put the IOL, it seems that the best IOL we can choose in this case is a single piece 6 millimeters IOL. Compared to the 3 pieces IOL, it seems it's much more stable. But we have to choose exactly which IOL we're going to push, because some myopia patients, they will never with the 3 pieces IOL. Also, some surgeons, they prefer to get the OBD into their chamber, and then they remove at the end of the procedure. I prefer to remove the OBD before doing the procedure. I want to do it one procedure, finish, then go for the next procedure also. And usually, I always suture the wound. Even if it's 2.2 incision, I will do the wound because they will prevent for leaking, and there will be less anterior chamber stability here. So talking about that, this is the procedure, okay? First I put the 3.5 millimeters trocar. Why? I put the first one here. Why? Because when you do the phaco, when I finish the phaco, the eye is going to be soft. So if I have one trocar inside the vitreous cavity, I can pressurize the eye very easily, and then I can put my other two trocars safely because the eye is going to be harder. Some surgeons, they prefer to put the 3 trocars at the same time here, but the problem is you need to remove it because you need to remove the 3 trocars. So it's better to put one on it. So as you see here, I made incisions in different places I may use it to, because I make my corneal incisions pending on where I'm going to put my trocar incisions. Okay? So look at the capsulorhexis I'm doing right now here. I don't get a big capsulorhexis size. Why? Because I don't want the lens to come out when you do the fluid exchange here. Usually, in these cases, I always use direct chop. Why? Because you reduce a lot of ultrasound for the patient. So I try not to do scalp at all, only ultrasound. So it makes, I would do less ultrasound to the patient, so the patient is going to do better and the cornea is going to suffer less. This is, I'm seeing right now with the chopper here. I look at this chopper, how effective is making the crack for the lens here. Now, I try to pierce the cut at the small pieces, and when you have those small pieces, remove one after the other. That's why you are effective using ultrasound, you damage less the cornea. So, as I told you, I remove all the viscoelastics here. One thing, it's very important to put mid-drain. I use it in the first video, I put the mid-drain, but I put only half. I do my phaco, and the other half I put it at the end of the case. I'm doing it right now. So I get the pupil dilated again. Okay, so this is good to dilate the pupil in 2 times here. The suture is here, and now I will connect my infusion line. Because the trocar is inside the eye is going to be pressurized, then I will put my other 2 trocars with a hard eye, so I can construct a very good entry for the sclerotomies in the eye here. Okay, this is the technique. There's no other thing like that. Okay, and you will see here, in these cases, the view is excellent. So the image we're going to read right now, this is the view during the surgery here. So if you do things on the right way, the cornea is crystal clear, so you can continue the procedure safely here. See, I'm doing vitrectomy right now, and this is at the end of the case. I'm filling the eye with silicone oil. I'm filling the eye with silicone oil here until the end. And I try always to put small bubble of air into the anterior chamber so to prevent the lens to come to the anterior chamber, okay? So, which are the tricks? Because this is the techniques, but you know, all the cases are not like that. Some of the cases I'm going to show you right now here, they are much more complicated. So we need to use a lot of tricks in these cases. That's why I told you that if you are a retinal surgeon, okay, you have to want to do phacovitrectomy. Better teach it yourself to do these skills because you will need it. For instance, the migraine, use half at the start of the case, half at the end of the case, so dilate the pupil again. Capsule staining, you have to have 0 degrees to stain the capsule. If you lose the capsule, stain it. You will see the capsule again. You have to have a small threshold to open the pupil. Don't let the pupil close down. So the pupil is closed, put X hooks, put Malogin rings, put whatever you want, use the covalent hooks, but open the pupil, because you will need the whole procedure. You will see right now, one example, we can use the light pipe to illuminate the eye, so we can be able to safely do the phacos in a patient who have no red reflex. So if you use the light pipe inside the eye, it's going to help us, as the case I want to show you right now to you, that it will help you to see what's happened. So we know if the capsule is broken or not, or we can do a very safe phaco, just using the light pipe inside the capsule. And also, if you think, for instance, that the capsule is compromised, think about safe, put a CTR, because it will be better for the patient, okay? One important thing also is about the infusion line placement. This is a fight I have with the fellows here. So you finish the phaco and you have shallow anterior chamber. So the fellow wants to go inside to inject to make the surgery. You cannot inject the patient because you already have the infusion line open. Even you close here, the vitreous is hydrated. So forget about that. Put your trocars and start your vitrectomy. You will remove the vitreous, the anterior chamber will get deepened, and then you can be able to do it on a better way. Don't fight the eye, because what you want to achieve is the iris, the iris get stuck into the wound, or more corneal edema, etc. Okay? This is an example of a cataract. Dr. DB will love about that. This is one of your patients. So this is a patient with a uveitic cataract that happens also, he was very unlucky to have a retinal detachment behind the eye here. So this is what the presentation of the patient, or with the B-scan compared to the retinal detachment here. And you see this synechius here. So after opening the pupil for this patient with covalent hooks here, we have a better, but still we don't have reflex here. So we can do. So I want to do a capsulorhexis, I don't have red reflex, I need to stain. Okay, so all these steps are going to be very, very fluent. Okay. Let's move it a little bit faster. So stain, you can stain by a viscoelastic in this case. You don't need to put bubble. You can stain with viscoelastic, and you can be able to stain the capsule and do the capsulorhexis for this patient. Okay. So, let's see, I can move it here. Now, look, I'm doing the capsulorhexis. I'm putting the light pipe through the corneal wound, and look at what happened. You can illuminate completely the procedure here. So you are very unsafe doing the phaco, you put the light pipe inside, now the phaco is very clear, so you know what you're doing for the patient, okay? That it works very well in patients without red reflex, but also works very well with patients with a bad cornea. If you have a patient with bad cornea, try to district because it helps you a lot, okay? So I'm using the cataract soft because it was a young patient, so cataract mostly aspirate the cataract here, and then put it in a little faster. Yeah, look, this is the retina. That's the reason you cannot be able to see. Look at this retina. It's totally detached with inflammatory deposit debris over there here. So they are complicated cases to do this technique, okay? So there's another one, which is also the paper from Sabatano is good, okay? Because they're prospective study. 110 cases, they say more or less is the same. Sequential to compare to the combined surgery here. There is one thing about the formula. It seems that the Barrett formula type 2, it's the formula that probably gets less errors, okay, when you calculate the length for this group of patients, okay. So put that in your mind so you can choose the formula. The new formula seems a little bit better, okay. Also, they speak always about this post-relief myopic shift. That's much common in patients with the gas tamponade here. So it's clear for the macular patients, we have to be careful about the myopic shift if we are going to use gas for the patients, but we can get good results here. What's happened with retinal detachment? I mean, it comes a little more compromised because there is a patient with leucobara. They say the reparations is higher if you do combining procedure, but it doesn't recommend to do combining procedure for retinal detachment surgery here. Okay, studied as a retrospective study when 126 patients, but also because we use gas all the time, we want to see this myopic shift all the time in the works here. Akiyama, which is also in green, is the one who studies which lens is better. And they say that it's better to use a single piece 6 millimeters IOL here than use a 3 pieces IOL. So it seems that the IOL we use normally in these patients are the best IOL we can use in these cases. There's also Sakamoto speaking about macular shift also, in retinal detachment macula on. And also they talk which is the better. So there's definitely you can use ultrasound biometry for macula on and macula of patients. You use ultrasound biometry macula of patients, you will fail the calculation by far. So if you have to do in these cases, it's better to shift to a new technology like IOL master based on the optical, or either better, it was the sweat source optical like the IOL master 700 we have here. Because it seems it is the machine can give you the best assessment of the preoperative biometry here. There's a lot of works like that. There's another one from Poncharemes, Onont, which also they say that you are underestimated the axial angle in these patients. You use ultrasound biometry here. Okay. Also, Mora has a perspective that's work with 30 patients only, but they say that conventional sequential are comparable in superior retinal detachment. Also, Benson, 300 patients retrospective here, combined surgery is safe and effective for primary focal retinal detachment. Kim speaks against. He has 82 patients that say combined surgery has no benefits in surgical outcomes in retinal detachment compared to sequential surgery. And this is important information about that. More intense complication is expected in fellow surgery. It means if the fellows are not expected into cataract surgery, they will have more complications. That's why it's better not to do combining procedures. Okay. Also, there is another nice paper from Musa. They say that the best technology you can use right now to calculate probability the IOL is to use source-based optical biometry here. Okay. Also, it's very interesting because the group from Funatsu, they study the regional difference in retinal detachment in Japan. And they find a difference, depending on the region of the patient is seen, they have more chances or less chances to have a combined focal retinal detachment. Why is telling that thing? It means it's very surgeon-dependent choice. If the surgeon is confident to do this phaco and vitrectomy at the same time, he will choose this as a solution because it will reduce a lot of the possibility of assessment for the patient. If you are in an area you don't have this kind of surgeons, maybe there is a chance you will have less chance to have a combined procedure. This excellent meta-analysis review from Shani, they say that there is no anatomical differences if you check for combined and sequential surgery in refractive retinal detachment. He analyzed 7 works and 2 randomized clinical trials just to get this information. It's clear that if you had a better refractive outcome if you do sequential surgery, but it's light only, it's less than half the diopter here. And with this comment at the end, they have low quality studies. Why? Because most of the cases they are well collected here are came from retrospective series or the case from group of patients done by one surgeon. So we don't have a lot of clinical trials to assess the good quality study. And this is something that maybe somebody want to work into that. Finally, we want to speak about other indications. So in general, for vitrectomy and for combined surgery here. So for instance, and this is very important, you will see that some of the criticisms they make about this technique you have more posterior synechias if you use the combined surgery here. But the only way to get rid of these synechias here is to use the back in the lens implant here. So this back in the lens is a intraocular lens designed by Tassignon, Maria Jose Tassignon here. But actually you construct a posterior capsule rexis and you put the lens in the middle of the capsules. That's why the lens is going to be in between the anterior and the posterior capsule here, and this lens is going to stay there. There will be no chance to have a posterior synechia on the eye here. This is the best we can do for these patients. Unfortunately, this lens is not available here. Okay. Also, another time, the myopia, if the gas is elevated. Another important thing from IWAMA is we can do aspheric IOLs, okay, safely in these patients, even if the IOL is a little bit decentered, because they don't get the high order aberrations for these patients. There is also Helberg studying the cause of the surgery. And he concludes in a prospective study that this surgery is better for the patient because it has less visits, and it's better for the institution because it has less cost for the surgery here. MILE also is a meta-analysis here, and the meta-analysis concludes for biometry in these patients that if you use ultrasound, you're wrong. It means optical ultrasound biometry is the way to go in these patients, okay? Also, there is a review from Aptel and also the Delphi collaboration here. They say these surgeries get more inflammation than the normal cataract surgery. So there's something to take into account. So it means probably you need to use non-inflammatory steroids here and anti-inflammatory steroids in this group of patients. Finally, El Husseini, they have a huge review of patients, 200,000 patients, and he concludes that you have high PCR rate complications in these patients if you do combined group. So here he advocates not to use combined with the sequential one because of the complications that happen during the phaco procedure. Okay? That's the laboratory review. I think I make it fast, but there's a lot of words. I try to highlight the most important ones here. So yeah, it's okay to do that, but what we do here? But it's really important to go to do your own assessment here. So what we do here? So I check my cases, okay? So my case, my knee and my fellows. Probably it's more my fellows than my cases. But anyway, so we combined surgery was offered to our patients. They were phakic, more than 50 years old, and they have any kind of vitreoretinal disease. We offer to remove the cataract at the same time here. So if we reviewed a group of patients, okay, this group of patients was collected from May 2020 to February 2022. So some of the fellows, they will be now present here, they will be moved into the study here. So we did 133 combined procedures. Okay, I want to highlight the number because you see in literature they do 20 cases, 40 cases, and they put this as a result here. We have more than 4 times this number of patients. Okay, and if I see the total vitrectomies we did in this period of time, 35% of our patients receive phacovitrectomy. So almost half. Okay, so there is a huge opportunity to do this surgery if you want to look into that. So, which is the main indication for the surgery? The start indication was rheumatoid retinal detachment. Okay, so this was the most frequent one, and followed by closely also for diabetic pathology, either tractional retinal detachment, either vitreous hemorrhage here. Finally, macular surgery is not as frequent in the kingdom, like it is, for instance, in Europe. In Europe, mostly 40–45% of your surgeries will do macular surgery only. Here, it's the less frequent group here. It's only 17% of the patients, okay? And finally, other some indications. Usually, patients with silicone oil and the cataract here, they go operated by other consultant, they give it to me, and I remove the cataract and the silicone oil at the same time here, okay? So, from these 130 cases, I have recorded the video, because I record all the surgeries here, for 108 cases. And then I can be able to measure how many times does it take to do phaco, because I told you it's a longer procedure. It takes you half an hour to do the cataract here. Okay, probably I'm not doing something right. So we check exactly which is the average duration of our procedure. It's 97 minutes. I'm talking about the whole. The range of years for 42 minutes, probably it was a cataract with a silicone removal, to 202 minutes, probably a complicated TRD. Okay, but these numbers, the average is 97 minutes. how many takes in average it takes the catheter for these patients? It's only 30 minutes. It's very few time, okay, and you get a huge benefit for the patient, okay. It's more or less 13% of the total time of the surgery. Okay, what were the outcomes? So we do 133 cases, 2 of them aborted. One, because the cornea was not clear, has CDK, we cannot see the fundus, so we do the catheter, we remove the trocar, we're going to continue the surgery here. The other has intraoperative corneal edema, so it means we can remove the trocar and we'll do the vitrectomy another day. Okay, so if you are hesitant about that, you can remove the trocar, put the stitch and halas. You don't harm the patient, okay? How many operations? And this is very important. So there's so many patients we operated, and we have to put the patient again to the operating theater. So 4 patients, 2 anterior chamber IOL. Remember what I'm telling to you, be careful with the capsulorhexis, you put the lens here, because you put gas, the lens will come out. 2 cases we have to reoperate the patient because the actives were out for the capsular back here. So we need to operate it. 1 was operated because it was a leaking wound, and another one it has an anterior chamber washout because one small piece of the lens was in the anterior chamber, so we need to remove it here. What about intraoperative complications? So 4 PCRs, not bad, okay? 2 the fellows, 1 the resident, 1 the consultant. Everybody happy, okay? And then, add to that, 2 major complications because these patients have to be aphakic here. They have 2 thoracic dialysis during the phaco. So in the thoracic dialysis, you don't have the chance to stabilize the retina. Probably you will remove the lens and the capsule at the same time here, leave the patient aphakic, and then continue your vitrectomy like that. So it was 1 for the consultant, 1 for the fellow, okay? But it's many more complications here. And also, which kind of post-operative complication we find in the group? Only 1. We need to do in 1 patient white IOLs change from single piece IOL to 3 pieces IOL because of the position of the lens here, okay? That's the total for 133 cases, okay? So it means we complete the procedure for almost the most of the patients, 98.5% of the patients, okay? So let's go to the flus, okay? So how many visits you have to do the cataract on this patient? So we calculate on a goodwill calculation 3 visits for every phaco. You have to go to anterior cement surgeon, 1 post-op, and 1 to remove the stitch. So 3 per 1. I'm trying to be very honest, okay? So if we do 131 procedures, phaco procedures, okay, and we don't have to do it, how many visits we save for the patient? Almost 400, which is a huge change, okay? Also, important thing, if you have a complication with the phaco, you can solve it during the surgery. It means we have 4 PCRs, we do it, everything for the patient. We solve it, we put the lens, and we continue with the surgery here. Nothing is going to happen. So it's good because you have a complication, you can fix it at the same procedure. You don't get another procedure for that. So in summary, okay, so for my opinion, I don't want to hear you about your opinions about that. So combined procedures is safe and effective, definitely for macular surgery, quite definitely for retinal detention surgery, and I'm more hesitant about vitreous hemorrhage and TRDs. Why? Because this population they usually have very complicated cataracts also. Probably complicated cataracts can be managed with a sequential approach. This is probably the safer way to approach this, okay? And very important, if you have vitreoretinal, team up with anterior segment surgeons. Your sensors, your colleagues, is your friends. Why? Because you need these people, they are experts into manage sometimes complicated cataracts, they can make your life easier, okay? So if you are not very well developed skills about cataract surgery, be wise. Choose easy cases and this complicated team up with anterior segment, which is going to help you, okay? Also, try to be honest with your skills. Don't try to learn phaco with these patients because you will be in trouble, okay? Because you have a lot of procedure to go. If you have complications, you cannot complete the vitreoretinal part of the procedure, okay? The specimen reports we have here, it seems that it's quite safe and good management for getting these patients, okay? But why we have some issues with this? Why some studies they found it here? Because in surgery, surgeon is the biggest bias here. So it means I don't want to know about the surgeons who did this surgery here, but I know that if these surgeons find difficulties doing things and some of your colleagues are not finding here, something has to be different. So when you study surgical series, it's very important to know the surgical bias. If you're not skilled into cataract surgery, don't go for that. Combining the rows, it gives you a little bit worse refractive outcomes, half a diopter, okay? Especially if you use gas here. The follow-up of the patient is excellent if you do combined surgery here. OR time to both for these cases are minimal. Less procedures, less complications. And finally, tertiary care hospitals truly benefits from their cost and visit saving here. And so the question is, me, I really prefer merit. So the question is, so any comments, no comments?
So thank you, Dr. Lopez, for this excellent review. So we'll open the floor for discussion. Dr. Paul.
Thank you, Dr. Rubio. If we see the following as a public healthcare system or a private system, what about the finance in related with this issue? Because I think it's an important topic. No, you mentioned it at the end as a finance, and we are a tertiary center, and it means a lot of cost for the hospital, doing the separate or progressive or sequential. But what about if you are in private? You know, what's going to be about the income of the surgeon, that there are issues that are raised in private practice?
So it depends of one of the first it depends of the part of the hour you were training. If you speak about the American surgeons, they tell you, if I remove the cataract for this patient, they aren't going to send me any patient anymore. Halas, I'm done. So the thing is, for them, it's usually an etiquette behavior to send the patient to a tear segment, they do the cataract, they send the patient back to you to do a bit of retinal here. If you learn to put the cataract for these patients, you'll be in trouble, because there will be no more referrals anymore. But if you are, on the other side, you are in Europe, the cost for a procedure, both procedures at the same time, you save 50% of the cost. It means, for instance, if you use a pack, you come back, we can do both surgeries. So you have only one machine, you can do both surgeries, so the cost is less. But more into that, imagine how many tickets for the patients coming here you save on. Imagine how many times with the people, the family coming here, you save on. So I mean, if you begin to think about that, then you realize it is a good idea. But all ideas, you can be try to make like a law written in stone. You have to be practical. Some patients, they deserve to have this surgery, and if there's more complications, you don't need to do it, because it's better for you also. So for me, finance is important, but honestly, I want to focus more into the clinical assessment of the patient. I think this also we have to take that into account, because, I mean, I know the quality comes with a price, okay, but we don't have to save so much money also, okay?
So Dr. David.
Thank you, Dr. for this review, and I like your way that you note and put it in the, in the contents of that. We have, scientific issues behind, a combined phaco plus vitrectomy. Not only that, to do it in the preference of the surgeons, because we know that there is a lot of people, maybe in the private, they like to do procedures combined because of the cost. And this is well known for us as a surgeons here. But here in the KK, sometimes we know that we have surgeons, groups of patients, like their age, about 50, especially diabetic patient, and they want to have tomorrow the cataract, so why I have to do this and to decrease, that. Some patients, they are coming to us who are young, myopic, RRDs, they're having macular problems, and we know that as a surgeons, combined procedure, it might be done by skilled persons, but there is an effects could be habit after that. So we will not always, advise unless there is a reasons. If there is no reasons, the media is not clear, the cataract is a bit, know that it will be go worse, we'll do the combined. But in case that you have no reason for that, I think so, provide that not going to do it unless it is required.
Yeah, I do agree with that, but we need to know also, for us as a vitreoretinal surgeons, there is a huge advantage to remove the cataract here. because you can feel better the peripheral vitreous. And for me,
not make it as a habit.
no. I'm
But
not
this
talking
is
about
what-
habit. I think about when you think about, for instance, you have speak about retinal detachment surgery. The best success is single success rate. We need to. This is our God. So we need to try to get the best outcome, surgical outcome for one surgery only. We know this is the most important risk factor for the patient to succeed here. So for me, and also working in a teaching institution, I think it's really good idea if we can be able to do it here because we are not harming the patient and maybe we'll do the surgery easier to be done. So that's why I do agree with you don't have to learn phaco doing vitrectomies. But it's a good idea to remove the lens in this group of patients. You can become a better shaving of the peripheral vitreous, better vitreous-based exploration, because the lens touch is 4 to 9% of the cases. It's not a small number, okay? We operate a lot of patients. So the thing is that it's always like a risk and benefit in life, okay? But I think that it's a good idea, you can be able to do it.
Thank you, Dr. Rubio, for your excellent information. Actually, this is one of the successful marriage in ophthalmology. And honestly speaking, if we go back to 15 years from now, we have too many patients referred from retina, from glaucoma, for cataract surgery. And that's what we need, many follow-up, and it's really helpful for the patient as well as the institute. So nowadays, with the new generation, all of them, they are phaco privileged and they are doing the phaco. We rarely nowadays find case for our resident, straightforward case for our resident and fellow. So I think this is important and I think we have to encourage this. And this is really a good practice and helpful for the patient, helpful for the institute. Thank you very much.
Yeah, I do agree with that. I have a question for the anterior segment people.
Let's hear Dr.
Thank you very much for your nice lecture. I think as long as the post-operative outcome or the long term, it will be the same, or as you showed. I think it's very, very important, and as I understood that the retina surgeon is not doing cataract surgery if it's not needed. But if it's obscuring his view, I think he has to be skilled. And I think I agree with my colleagues that every retinal surgeon should be qualified to perform perfect phacoemulsification. Because we used sometimes that the retinal surgeon will come and the cataract is obscuring his view, and he go and do by pars plana vitrectomy, and he remove the lens and leave the eye phakic. Then he will send it to the anterior segment to do sclerofixation, especially if he didn't leave any capsular remnants. I think it doubled the work in the institution and so on. I think we encourage that the retinal surgeon, as long as they qualified for retinal surgery, they should be qualified in phacoemulsification and have a good outcome for the sake of the benefit of patients. The visual outcome will be the same, and they will drop a lot of burdens on the patients from coming to be treated in the institution. Thank you very much.
Yeah, so there is a lot of discussion in this. So there are two extremes, in my opinion. The American extreme, which is refer all cases to anterior segment because they don't want to lose the referral source, and there is this European way, any patient above 50 years should have cataract with vitrectomy done, even if the lens is clear. And I think we should hold the stick in the middle and do it when you need it, but don't overdo it, in my opinion.
But I like his way. There is some cases where very complicated cases
Yes.
of cataract. Sometimes the retina surgeons, they are not
You don't have to do it.
practice to do these things. So that's where you have to keep the relation with the anterior segment. We'll not leave anterior segment without marriage. We have to be all the times.
Yeah, but you can ask
But
a
I agree with
question.
Dr.
So there is
Farad that all
this,
the retina surgeons,
yeah.
they have to be familiar with
Yeah, but there are certain scenarios where, in my opinion, doing simultaneous surgery is more harmful. Like what you mentioned, patients who have vitreous hemorrhage, diabetic traction, maybe the phaco after doing your vitrectomy is easier. Also more inflammation in these cases because we do a lot of laser during vitrectomy for diabetic patients, and laser can induce inflammation. They can have more posterior synechiae. I had patients who had iris bombay because of the posterior synechiae. So it is not, it is individualized. It is not a rule, but it is a very interesting discussion.
But this is good that it's not free of complications. There is gas, it could push all the, diaphragm anteriorly. It might lead to, as you said, papillary block. It might be the, silicone oil escape in the, through the zonules, next zonules to anterior chamber, and this is another, scenario. Second, they will find your patient having 50 millimeter of mercury. This is all things that we have to be aware how to deal with it. This is not an easy things that when you do combined procedures. So we put this in our mind. Otherwise, you don't have to do it if you are not able to recognize which case are.
Yes.
Especially with this glaucoma patients.
Just a small comment or a question. What is your way or the best way to decrease the amount of error in IOL calculations, especially if you have retinal detachment?
See, you have a retinal detachment, you're going to use gas or silicone oil, but your model is the same. There's no difference between using gas or silicone oil here. So you know there's going to be a myopic shift because the position of the lens is going to be different. You do a cataract in these cases. And it's been studied in all pathologists. Even patients with macular hole, they don't have retinal detachment, but they go to gas tamponade, and this happens the same thing. So this myopic shift, it happens. But they put numbers on the thing, because I think something, we call it is like, okay, something is statistically significant, but it's clinically relevant. So do you really feel that less than half diopter of difference, this is what we're talking about with the myopic shift here. It counts a lot in this group of patients. My patients trust me, and I would love that it will make a difference, but they are not different at all. So most of our patients, the visual aggravity is precluded by the macular pathology here. Okay.
Did you study this?
No, I cannot study because as you may understand, I collect the cases, I review the cases, and I don't have the refraction for the cases. But let me tell you something. If I find the patient is not improving, and I find the patient needs a higher glass because it was a big mistake in the IO calculation here, I will know that, because I will know with the pinhole is going to be better. No case in 133 cases happened that. More into that, I have another series from Spain, where I have doing primary retinal detachment surgery. It was 260 patients, I remember by mind here. So I don't study because some of the patients, they made pseudophakia on the time. No patient need an IOL exchange because of that. Because the amount of myopic shift is very low. It's only half diopter, no more than 1 diopter here. Anything can correct it with glasses. We are not refractive surgeons. I am not a refractive surgeon. But this myopic shift, it happens, can be corrected, and it seems it's quite low if you use optic biometry here, like the size 700 IOL master.
Marcus, do you like to measure the IOL before the procedure? Suppose that you are going to do surgery tomorrow,
of course,
an IOL today, and then you put silicone oil. After 3 months, 4 months, you will, remove your silicone oil with cataract. So, is it that helpful?
Yeah, but the problem is, the patients you usually have to put silicone oil, if they are macular patients, these are the patients you're going to fail for more. If there is a scenario from vitreoretinal surgery, they have more chances to fail the IOL calculation, is macula of retinal detachment patients, okay? So, for instance, it's a diabetic patient, because the retina is not going to detach it, probably the calculation is going to work here. But unfortunately for us, it's not a big issue if you fail 1 diopter. Our patients doesn't see better or worse because of that. I would love that it will be an issue, but it's not. Let me ask you a question, because
So thank you, Dr. Robi, for this comprehensive review and for the discussion. So for me, I think the main 2 issues with combined cases, as you elegantly described, is the inflammation
and the IOL calculation, and these are significant issues. And let me share with you one case that I have seen today. This is her first post-op visit. So that patient was diabetic patient, extramacular TRD with vitreous hemorrhage. So I saw the patient 2 or 3 weeks ago and I booked her for surgery last week or the week before. Anyways, so IOL calculation was done. So usually the practice there is those patients are day case patients, so they are not usually admitted. Anyways, so IOL calculation was done 1 day before the surgery and after I saw her in the clinic. Okay, and I operated her, combined phacovitrectomy. She was having NS+2 with some cortical, but I could do vitrectomy without phaco. But I've done the combined. And when I saw posteriorly, she was having subhyaloid hemorrhage, extramacular detachment, and then I operated. When I saw her today, I was actually surprised. One, her vision was counting fingers, and before surgery it is counting fingers, and I thought that her vision would be better. And the cause of this was 2 things. One, significant posterior synechia and significant severe pupillary membrane in front of the IOL. And the second thing, when I do for her autoref, she was -4. So, so these issues are really severe issues. So, I remember that one study was published recently, not for phacovitrectomy, but for phaco in general. Those patients, and this is like a new entity called EPIC. So, if I remember, idiopathic persistent inflammation post-cataract surgery, and this was seen in patients who are African American women, and she's African Saudi woman, and she was having this significant inflammation. And after this case, and I think most of us will be influenced by the cases that they do, not by the studies, because the studies, we know, many studies are outside the country, different population, different diseases, as you have mentioned, so TRD, subhyaloid hemorrhage, and so on. So in the future, what I'm going to do, if I can do vitrectomy, even if there is cataract, I will do it without phaco surgery. So, so just this is the thing that I wanted to share with you, because it's really significant. Now the patient will be booked for membranectomy and IOL exchange in a few weeks.
Yeah, this is the thing about this subject. It is subjected to anecdotal experience, and people start their career doing combined, then with time seeing more and more complications, then they start to shift to less and less. So in surgery in general, we try to be minimalists, and if you can do one procedure, let's say for an RRD, if you can do it with pneumatic retinopexy, it is better than if you do oscillobacter. It is better than doing vitrectomy. Yeah.
The issue is the buckle.
Yeah, but the thing is, for instance, you put a buckle, you change the refraction also.
So you have a question that you wanted to ask?
Yes, I want to ask the people that are involved in the lateral cement surgery, what do you think about that? Because, which is better for you? That I remove the cataract at the start of the procedure, or I do the vitrectomy, I do the patient with the vitreous, with the loosened formulas, and they say
So maybe Dr. Farhan is the only person I have. So I will rephrase the question. Do you prefer that, let's say there is an elective retinal pathology, do you prefer that you do the cataract first, or we do our vitrectomy, then you do the cataract later?
Actually, it depends upon the situation. Just before I answer this question, I think, and part of it, if you are forced to do combined, I suggest that we have to start intensive steroid course to help to alleviate the inflammation after surgery. And I agree with the doctor that if you do more, if you manipulate the eye more, you will have inflammation more. That's a fact. What I would do, or what I prefer, that if there is elective retina surgery and the lens is clear, I will not touch it. I will do the retina surgery and leave it. But if there is cataract which is obscuring my way, instead of asking the anterior segment to do the cataract, send it, and I think I don't want to delay the retina. The retina is more important than the cataract to remove. I would encourage a skillful surgeon for phaco and retina to perform it with immense preoperative steroid course.
But there's something that I answered to both questions also from Tarek. I mean, you choose the wrong patient. Because if the patient has high inflammation, is a vitrectomy, is a diabetic patient. So many, if we speak about macular surgery, I tell you, 100% of the patients nowadays in Europe are operating with phacovitrectomy class. I mean the numbers. Second thing, if you operate phaco only in a diabetic patients, you can have synechias also. Why? Because the lens, we decide the lens on the wrong way. Honestly, it has to be clear to you, maybe the best way not to have this, if you don't have this IOL, is to create a posterior capsulorhexis, good at 3 pieces IOL, and do reverse capture of the optic. That will solve the problem of the issue of the stability of the lens and also the problem of the synechias here. But let me ask you about that, the question you make it here, because I want to share with you another history. I remember I have a patient back in Barcelona, I have a retinal detachment in both eyes. I operated one eye, they don't operate the other one. So the patient knows that I do cataract surgery. Okay, he told me, no, doctor, I'd rather prefer you to do my surgery. I told him, don't worry, we have our 7 colleagues, they are very nice, they will do it to you. You know what's happened? They dropped the nucleus to the vitreous cavity. I have to reoperate the patient again. And then I have to do the other eye. I will remember all my life. The patient is telling to me, doctor, you put me in trouble, now I see very well, please don't do that to me. I mean, you are very unlucky, it's going to happen once. You know what's happened to the other eye? Drop it to the vitreous cavity. And then I will remember the guy in the pre-hospitalization, doctor, I told you what's happened there. So, I mean, these are things that if you think about in our point, for me, you know, if I don't have to do the phaco, it's faster for me, and I will finish early. But the thing is, sometimes we need to see the whole picture. And the whole picture, sometimes these patients, I totally agree that they cannot go for combined surgery. But you have a patient with an easy cataract that you can be able to manage on the right way, and you can add some extra care for the vitreous base here. Finally, I will feel much more comfortable if I do the phacovitrectomy here. And just to add about that, it's not the first and the second patient I have to do lensectomy because it was touched during the surgery here. Because we are teaching people. And the people we are teaching, sometimes they are more skillful, and sometimes they are not so much. So it's something also to take into your mind here. It's a teaching institution, we need also to have this into account here. But I totally agree with you.